Those who watch the programme regularly will have heard of CIT Marbella. It's a fabulous business networking association, very well established in the Spanish system. So whether you're a Spanish or English or international company, small or large, this is certainly an association that's interesting for you. Also, for over a decade now, they've been sending one of the members to my programme so that we get to meet the different people that make up our fabulous city. I'm delighted to welcome today Dr. Thomas Boerger, and he is a traumatologist, but you are...
And an orthopedic surgeon.
An orthopedic surgeon. I've been
Correct.
practicing that all morning. Orthopedic. I even looked it up to see what orthopedic surgeons do, because fortunately, I've never needed one. Thomas, how lovely to welcome you to Marbella Now.
Thank you very much for having me. It's wonderful.
My pleasure. Where are you from originally?
I grew up in Berlin, which used to be West Berlin, and I went to medical school there. And then somebody invited me to come over to London, and I did all my training there after in London. And eventually I migrated to this part of the world.
How long have you been on the coast?
About 18 years.
18 years?
Yes.
Oh, so you're certainly part of the furniture.
Well, not really. Maybe.
You're with HC International, which is a lovely hospital, or it's a very, very pleasant. It's hard to know that you're actually going into a hospital when you go there, because it's also very welcoming and pretty and lovely.
Yes.
And orthopedic surgeons I now deal with when you have broken bones and I suppose arthritic complaints as well.
Correct.
Anything to do with the actual skeleton and things that happen to us. And as we get older, things happen to us.
Exactly. So at HC, I'm concentrating on hips and knees, mainly on knees.
Well, there you go.
Exactly.
Well, there you go.
Very important if you
Very
want to walk.
suitable for the community that makes up Marbella.
Exactly.
How do people... Because you hear this all the time, broken my hip.
Yes.
This seems to be a very common thing, and the same thing as damaging our knees. Why is this such a typical problem as we get older?
Well, the fracture of the hip or the neck or femur is a problem of the osteoporotic bone. And osteoporotic bones are getting softer, and small falls or twisting movements can cause a fracture of this bone. That's the upper end of the thigh bone, which is really very close to the hip joint, and fractures there, well, are very life-changing
So it comes
events.
to the osteoporosis syndrome, which again is also very synonymous with particularly women, isn't it? That's more tendon.
Yeah, we call them fragility fractures. The bone gets soft. We have similar problems in the spine or in the wrist. These three areas are very typical for people with osteoporosis. And it affects men and women. Women maybe a little bit more than men. And that's an acute problem. Whilst we deal with this as a traumatologist, I deal with this about 100 times a year, but not at HC. At HC, I'm concentrating on the elective side of orthopedics, which is the planned treatment of conditions.
And who would need a planned treatment?
Somebody who has pain in the knee and the pain is getting gradually worse, and the house doctor or the general practitioner has prescribed painkillers, and the painkillers initially work and then they don't work anymore, and eventually it becomes so bad that patients can't really walk anymore, and that's when they come usually and see an orthopedic doctor.
And what kind of things can you do to help that? Particularly if the bones are soft, where do you hook things into if bones are soft?
Exactly. So, I mean, we try to do as little as possible or as little as necessary, and obviously if it's possible to make people more comfortable without an operation, then we try that, and that could be advice on physiotherapy, an injection into the knee with steroid or with a gel. But often patients come with more advanced osteoarthritis, wear and tear in their knee, and we then quite frequently see that bone is already grinding on bone and the leg becomes bent.
It's hurting me just hearing you talk about it. My whole body's cringing.
And these patients, obviously we assess them, we examine them, we listen to their history and their development of their complaints, and we get x-rays. And once the x-rays show that there is bone rubbing on bone in a joint, say for instance the knee joint, we can then discuss joint replacement. And joint replacement is routine surgery and routine treatment for many years, but it has gradually evolved.
I'm thinking back to the old days, and you think about replacing joints, and then thinking of like the 3D printers and the things that they can make now. It must be very exciting for you in your profession to see the options that have opened up to you, I would imagine, over the past few decades.
Yes, I mean, the joints have changed, the implants have changed themselves, but also the way we put them in. Say in the 60s, the surgeon would see the bone and take a saw and make a cut, and that should be good. And then in the 70s and 80s, more refined jigs and tools were sort of developed that would help you to get the cuts correct and get the leg alignment as well as possible. And in the last few years, the development has been to use electronics or computers and robotics to further refine and improve the process of implanting these joints. So it's not about necessarily printing the joints for a patient, it's about getting the joint into the best possible position, which allows a natural and a patient-specific leg alignment, and to get a ligament balance in the knee that gives you a knee that is really stable throughout the range of movement, not slack when you bend it. And whilst this is possible with mechanical or traditional instruments, we've now made a step where we're using computer-aided and intelligent instruments, which basically allow us to plan the operation before we actually do the operation. Would you like me to talk a little bit about
Yes, I
more
would.
about that?
Yes, I would. I mean, just thinking of AI and all the abilities I have in my work-day, that could be useful for you is interesting.
So basically, it is an operation like a regular knee replacement. The patient's in the operating theater, and we have to open the knee. I don't want to get into details here. And we have to apply a couple of markers to the shin bone and the thigh bone. And these communicate with the computer. And then we teach the computer where the leg is and how the leg is shaped. And to do that, we'll scan in points of the ankle, we'll scan in central points in the shin and the thigh bone, and we'll scan in the center of the hip by rotating the hip. And the computer learns the leg alignment, and he learns the leg alignment through the range of movement as well. And then we register the joint surface. That means we have a stylus and we draw along the joint surface. As we draw along the joint surface, a picture develops of the virtual knee as it is in the patient. And once this process is complete, it takes about 5 minutes, the computer understands the dynamic, understands the anatomy of the leg, but also how the leg moves and what the dynamic of the ligaments is and so forth. And then the computer can give us a generic position of the implant, and then we can refine the position by moving it virtually on the screen. We have a sterile screen, and we can just move the implants a little bit. And with every movement, we can immediately see how it affects the leg axis, the alignment, or the ligament balance, and so forth. And so we're trying to not have a standard leg alignment, which one fits all. We want to have a leg alignment that matches the patient's original anatomy. And we'll do that by moving the implants by half a degree this way or that way and shifting them around until we're completely happy that the implant position will give the best possible outcome. And only then, and that process takes another 5 minutes, and only then we press a button and then we use the robotic part, and that is a handheld robotic tool that helps us remove the bone only where it's necessary. And the tool is guided by the computer. It also communicates with the computer or with the robot, and it only cuts bone where we want to cut bone. So even if you hold it in the wrong position, it will not cut. It will only cut exactly where it was planned to remove some bone. So when we talk about not cutting away the knee like this, we're really talking about a few millimeters on the edge of the joint, because what it is at the end of the day, it is a joint resurfacing with that.
It's funny how you're saying this. I'm thinking of my German Shepherd,
yes.
which is very often a problem with them, is that they have this problem with the socket of their...
Well, this is arthritis usually.
Interesting.
Yeah. So once we have planned the operation, and we can carry then out the bone resection. We then put a trial in, and then we can trial it again and move it again, and the computer will recognize, and we can then see whether we have achieved what we set out in the beginning of the operation. And only once we're really happy that actually the knee moves as we want it to move, the ligaments are stable as they should be, that's when we then glue the final prosthesis into the bone, and then we close up.
Wow. I would imagine with all these advancements then the recovery time is also a lot better than it would have been before, if you're being more precise and...
I'm not sure whether the recovery time is hugely different, but what it is, the precision of the implant is better, and the leg alignment is planned. It's not one leg alignment that the jig tells you to choose. It is a leg alignment that you're choosing to recreate the patient's anatomy.
What kind of time is there for recovery when someone has a hip
or knee replacement?
Knee replacement?
Knee replacements probably take a little bit longer. Patients stay 2-3 days, sometimes 4 days in the hospital. They will use crutches for the first 2 or 3 weeks, and by 6 weeks they come off the crutches and they think they're good. But in effect, there is still rehab in progress. When I see my patients at 6 months, they think they're perfect, but it is only probably after a year that they really forget about their knee. And that's what we want. We want
but I suppose if they've been in pain for so long, not having that excruciating pain makes them feel better, because comparably they're a lot better.
Absolutely.
Which is good.
The excruciating pain from the arthritis is gone after the operation. Obviously, this is an operation which includes cutting bone, and cutting bone causes post-operative pain, and we manage that.
Is this the same type of procedure if you've got arthritic hands or things like that, or is it each part of the body has certain options that you can do?
Yeah, and there are different procedures for different parts of the anatomy, but joint replacement can be done in the shoulder, in the hip, in the knee, in the ankle, and also in fingers. So yes, there is a similarity, and yet it's appropriate.
Why did you choose this speciality of medicine?
It was coincidence, I suppose. I had an uncle who was an orthopedic surgeon. That was a little bit of a role model. And then I came to London, and my consultant at the old Westminster Hospital, which is a traditional teaching hospital, said, "So Thomas, what do you want to do with your life?" And I said, well, once I had a sort of a spark and a quick thought, and I thought he's an orthopedic surgeon, I better say orthopedics. So I said, orthopedics, I want to be an orthopedic surgeon. And he said, well, I'm sure we can help you along, and he did. And you know, the struggles from being a junior doctor, getting into training programs and so forth, that's very competitive. And I had a little bit of a supporter there, a mentor, I would say.
And how nice that you can carry that on here on the coast and do what you like doing. Do you also play golf and other things?
Well, I used to, but I got too busy to play golf.
Too successful?
I don't think. I think, yes, I still work in a public hospital settings where I work long hours and where I do a lot of these operations.
So you're a nice person as well, not just a good doctor, but also a good guy.
I think so. I think the balance of both is good. I mean, obviously HC is a private hospital and we do private medicine, but I think it's also fair to you know,
to give
provide for the community, and
well,
I do that.
It's a pleasure to meet you, Dr. Thomas Boerger.
Thank you very much.
Boerger, if you're saying it in the German way.
Correct.
Das ist good. Thank you ever so much, and thank you to CIT Marbella. And you just heard, any problems with your knees, this doctor is the guy to sort it out for you. Thank you
very much. Thank you so much. Bye-bye.
Hey, hey.